This is the effects of sex and gender on obesity and impact on cardiovascular disease. No disclosures. I'm Ynhi. I'm at Baylor. I'm the Assistant Director of Justice, Diversity, Equity, and Inclusion. And we have Dr. McGregor here as well from Prisma Health. She's the Associate Dean there. And we had two other presenters that couldn't come that were a part of this. Dr. Connie Newman, who's actually an endocrinologist at New York University, and Nina, who's a wonderful medical student, or not even a medical student, undergraduate student at Brown. Like, she's amazing. She is.
Reached out and was like, what can I do? And she's just been doing so many projects and getting published with us. Yeah, it's really neat.
So, and this was a paper before it was a talk. So I'll hand it over to Dr. McGregor to do the introduction.
Okay, perfect. So I look at this as 18 years ago I was an intern in emergency medicine, and I think about how things have evolved since then. We know science evolves, research evolves, and so does our practice of emergency medicine. And so I think it's important for us to continue to think of these things as this is sort of the next level that we need to go to. We were taught that men and women were the same outside of their external genitalia. So we can think back to our biology class in high school. The sperm meets the egg. They get together, and you get either XX or XY chromosomes, and that determines whether you get ovaries or testes, and then that determines whether you have testosterone or estrogen, and that gives you your secondary sex characteristics. So your breasts and hair, and then that's it. And then other than that, we're pretty much identical. But if you practice medicine, you, especially in the ED, where you see so many different, everything, if it can happen in the world, it comes in your door. The truth is that men and women are not the same. And even if a disease occurs in one or the other, someone seems to have a greater incidence or greater severity. So 78% of all autoimmune diseases occur in women. Sudden cardiac death is 30 times more likely in men during exercise than women. We now know heart failure with reduced ejection fraction and heart failure with preserved ejection fraction have sex-specific incidences, and it has to do with responding to the pressure overload. Women are more likely to have hip fractures and irritable bowel and migraine, and so there are these important differences. Why haven't we really realized that is because we have been studying men in clinical trials. Men were considered very stable, not variable. They don't have a menstrual cycle that can get in the way. And when we were really focusing on our large cardiovascular trials and our stroke trials and sepsis, that was at the time where women were considered a protected subject from research. So we didn't want to have a teratogenic effect. We didn't want to have another thalidomide event. So it was thought, let's just protect women and just study men and take what our results are and apply them to both men and women. And then we realized, well, the women's movement, 1970s, they really sort of highlighted the fact that we don't know a lot about women's unique bodies and women's health outside of the reproductive system. So that sort of brought this to light, and then the National Institutes of Health Revitalization Act in 1993 said, well, we should probably start to include women and minorities in the later stages of the clinical trials, right? So at least near the end, we should just make sure that it fits with these other populations. And we thought that it's a start. But then we realized that we don't understand a lot about the mechanisms of those differences. So the NIH said, as of 2016, we need to include sex as a biological variable through the preclinical studies, through the animal studies. So that way we're not shocked when we see a difference at 10 years later and $1 billion later after all of this understanding has been laid out. So here is where we are now. So the NIH said in 2016, include sex as a biological variable. So a lot of people think that means just including women in a study. And so what we're really understanding now, it's not just about inclusion, it's about sex-specific analysis. So, in other words, analyzing it to determine if there are differences. Here's an example. This particular researcher wanted to see if high-dose naltrexone, which is Narcan, oral, high dose, if they gave that to men and women who had cocaine use disorders, maybe that would help decrease the amount of cocaine that they used. So the bottom axis is time, and the vertical axis is urine drug screens for cocaine. And what they did was they used a placebo, and they gave a placebo to both men and women, and we learned that they did about the same amount of cocaine use over time than each other. And then they gave the study drug to men, and men decreased the amount of cocaine use that they were doing. When they gave the study drug to women, it increased the amount of cocaine that they were doing. So when you look at this and you think, if this researcher had pooled the results, what would have been what would have happened? Since it's just two of you. Say that again? Yeah, it would average out. It would look like this is a null study, right? Instead, we missed out on something that might be beneficial to men or might be harmful to women. So I think this is a great example of why we need to really tease it out, because where we are now in the future is when we see a sex difference like that, the exciting part is, what's the source of that sex difference? Why did that happen? Was it related to the pharmacokinetics of the drug? Is it related to gender differences in their cocaine use disorder or blunting their effects? So this is where it's really exciting, because we're going to find a greater understanding, a scientific understanding, of where that sex difference is coming from. So could be a couple of things that could have contributed to that. One, the thing that I think is super interesting and important is the biological sex, that DNA card, right, that we think only affects your ovaries and testes. But actually that DNA, those sex chromosomes, are in every cell in the body, right? They're in the liver. And we now know that there's over 1,000 genes, enzymes, there's over 1,000 enzymes in the liver that have sexual dimorphism in animal studies. So that means they act differently depending on if they're in a male body or a female body. Those chromosomes are in the heart, and they affect the way that coronary arteries develop plaque, and they affect the way that that particular heart manages high blood pressure. They're in the kidneys. They affect excretion rates. Tylenol in men have a 33 greater excretion rate. Benzos also a faster excretion rate in men. They're in the lungs. If men and women smoke the same amount of years and then they both stop, the women's lungs will recover quicker. It also has to do with COVID receptors in the lungs and the differences between susceptibility to men and women. They're in the stomach. Women have slower gastric emptying times. They have slower intestinal transit times. And they're in the brain, and there's a lot of interesting and controversial data that's looking at that. Or maybe it has to do with hormones, this thing that we've ignored all this time. The men, in 20, 30, and 40, those really stable testosterone levels, that has been that's who we've studied. That has been the basis of our understanding of medicine, has been on this really stable grouping. But that's not reality. And we haven't really looked at the fact that, over time, these hormone levels change. For women, they change, throughout the course of a month and the lifetime. And we've just completely forgot to study that, because we wanted to make sure that everything was not complicated. When we first were getting into science, it was like, let's take out all these confounding variables and we want to know what's really going on. And what we found out is what's really going on in men. And for instance, when you think of seizure medication, so anti-epileptics, in the emergency department, if a woman comes in because she had a seizure, what do? We say, okay, you can't drive, or go follow up with your neurologist, or, well, let's take that anti-epileptic drug that you're on and we'll increase the dose for every day. When actually, if you look at the data, during certain times of the menstrual cycle, because of these hormone changes, it can decrease the threshold of that drug. So you'll have more likely to have breakthrough seizures. So why don't we tailor this to women? Why don't we say, oh, if this is your cycle, during this time take this dose, during this time take this dose? This happens also in pregnancy, and we're not tailoring this to women. Or is that difference due to environment, like gender? So these are all environmental effects or impacts on health and disease. And not all of these are actually visible. So sexual orientation may not be visible. Gender, if we stick to that for this topic, is something that people assume by how you look. And so these things do affect health. I usually use the example of women who wear a burqa in their society. And I'm just so upset about what's going on in Afghanistan right now with the burqa issue. But if we just think about that, and we think of women who cover themselves as a cultural gender rule, they're less likely to have skin cancer. They're also probably to have lower vitamin D levels. Right? So that's just one example of culture and gender. My trauma rooms filled with men, right? We expect them to get up on the roofs and they fall off the ladders and they lose their fingers for the snowblower, right? So we have all of these sort of cultural expectations, and maybe it has to do with that. Maybe that's affecting outcomes. So I think it's really important to look at the terminology. So when we are talking about sex, that's the biological construct. That means genes, chromosomes, really getting down to the DNA level. Gender is that social construct, and there's external gender, and then there's internal self. The external is what we sort of not force, but what society sort of imparts. But now we know that gender identity can be completely variable and very internal and personal. And then when we talk about transgender, we're talking about the discordance between those, the sex and the gender. Oops, I'm pressing the wrong button. So when we think about it, we think about doctors are always like, we're practicing evidence-based medicine. Like a lot of this is all evidence-based medicine here, right? But when we think about the fact that we're practicing evidence-based medicine, what is that evidence based upon? When 76% of cell-based researchers don't know the sex of the cell that they're working on. They have no idea. These cell lines have been around forever, and how does that affect that outcome of that study? How does that affect their analysis, their hypothesis? 80% of animal models are still male animals. Yes, we are enrolling women more than ever in human clinical trials, but it's not just about inclusion of women now. We can't just sprinkle a few women in a study. As I demonstrated, we have to really analyze it to determine if there are differences there. Women make up over half the population, and so we are the healthcare deciders for many of our families. So, when I see a patient in the emergency department, how does that influence my clinical practice of evidence? It's not generalizable to most people that we see. So we looked at cardiovascular trials, and it's a pipeline issue. So what you put in is what you end up getting out. So one of the reasons why we look, why aren't women, now that we want to enroll women into clinical trials, why aren't more of them coming? And we really looked at the fact that it's the pre-screening. If we go to enroll subjects at Home Depot versus a school or the grocery store or churches, we've looked at even the fact of race. If you're trying to enroll someone in clinical trial and you don't look like them, then they're probably not going to, there's distrust. They may not enroll into the study. There's a lot of research on that with the gender of the physicians as well. So this is a really pipeline problem. What has this done? It's made women more likely to die after having a heart attack. Women are less likely to be recognized as having a heart attack. They're less likely to receive evidence-based medicine compared to men. They're more likely to die in the hospital before being discharged than men. And so we start to think about, well, why? And you go back to all of those options, right? We were taught in medical school and in residency and on-the-job training and that this is what a heart attack looks like. That it's this white male, metabolic syndrome likely, clutching his chest. This is still taught today. I was asked to review some materials for medical students and residents to pass their boards, and the same photos, a white man with a belly, with balding, sweating, down the left arm. No wonder why we're missing heart attacks in women, because women don't present like that. Chest pain is the most common presentation for both men and women, but they might not express it that way. Women are more likely to have dizziness, unusual fatigue, shortness of breath. I mean, if these women come into your emergency department, are you going to recognize that you should think of cardiovascular disease, right? Is your triage nurse going to recognize and get an EKG? This just delays. The patient doesn't realize it because of public health measures. We're not telling them that it could look differently than men. And so, how many of you practice clinically? Okay, so here's an example. Here's a patient example. And so this is a woman. She's probably 45. She's premenopausal. And she's at work, and she's like, oh, I got this chest discomfort, which is what women mostly say. And her colleagues are like, coworkers are you don't look it. Maybe you should go to the emergency department. So she's like, oh, I got all these deadlines, and all right. And she goes to the emergency department, and there's fluorescent lights, and it's really, nerve-wracking. We forget what it's like as a patient to walk into that environment. So the doctor sees her and says, you look anxious. How about some Ativan? And you have a history of anxiety here. Maybe this is just your anxiety. And she's like, maybe. So she takes the Ativan, and she's like, I feel like I had a glass of wine. I don't care about my deadlines anymore, but the chest discomfort is still there. So the doctor looks at her past medical history and says, oh, I see you're taking ranitidine. This must be your GERD. So here's a lidocaine Maalox mixture, and she takes that, and the doctor checks back, and she's like, it's not, my throat is numb now, but it didn't do anything to the chest discomfort. And the doctor goes, well, if it's tender when I press here, it's got to be musculoskeletal. Here's some ibuprofen. She takes the ibuprofen. And then he checks back, and she looks like she's in pain. She's like, it's getting worse now. It's starting to get worse. So the doctor's like, well, just here's some morphine while I guess I'll order labs, or, we'll start to look at other things, without realizing that women are more likely to have respiratory depression with opiates, more likely to have nausea and vomiting. So now she's put on the monitor, and now she needs some anti-nausea medications. And then some of the stuff comes back, and she finally gets a nitroglycerin, and then she needs some Tylenol for her headache. How far do you think this is far from the truth, from what you experience if you were clinically? I mean, we really don't know how all of these drugs work together. And for women, we're seeing what sticks. We're constantly just seeing what sticks. Because we don't understand the mechanism of the pathology of disease, of microvascular disease, of the way that they develop plaque, of the way that they present with their symptoms. So this is what women, across the world are hearing. They feel as though that these symptoms are all in their head. It must be their problem. It must be their anxiety. It's maybe it has to do with their pregnancy. This is how women are feeling, and it really has to do with the fact that we have not studied women appropriately. Wrapping up, because we wanted to make a connection with obesity, which Dr. Thomas will take over next, is just even looking at this. So what's wrong with this title, Gender Differences in the Effects of Cardiovascular Drugs? So but we said that, if we're talking about pharmacokinetics and pharmacodynamics, we're talking about the DNA. So we refer to that as sex. Sex was not a term used in research up until NIH started using it. And so a lot of research conflates those two. Now there's specific definitions, and so when you look at something like this, you just have to change it in your mind. This is a super robust paper because it actually goes through lots of cardiovascular drugs and the differences. So I like this particular chart. Again, they say gender differences, but that's not true. So when you look at, I don't have my glasses. I can't see. Do I have my glasses over there? It's small. Or I could do this. I'm aging myself now. So yes, okay, so absorption, distribution, metabolism, okay, that's all pharmacokinetics. Drug bioavailability, look at, there's all these differences. In body composition that we don't think about, and this also changes as women go through the menstrual cycle too. Body weight, body water changes, that also changes drugs, drug distribution, drug transporters, metabolizing enzymes, all of these things, but we're not taking them into account. So if we're seeing these things, and then their second table was sex-related differences, and there's some examples here. And just for instance, labetalol, right? The concentrations are 80% higher in women. So I've read that labetalol will last 8 hours more in women than in men. We're not changing the dose. We're not changing when we go on Hippocrates and look, there's no instructions to do that. Procainamide. The plasma levels are higher in women, right? So, gosh, I would like to know that. Zolpidem, again, a flagship medication. Women metabolize the drug at a slower rate than men. So this was the first sex-specific recommendation from the FDA that men should get 10 milligrams and women should get 5. That's after 20 years of prescribing 10 milligrams to women, having them wake up and get in car accidents as they're impaired. And then other things like, when you look at pharmacodynamics, so this is what the drug does to the body. And it's not just about dosing or side effects, it's about indication. So, these studies years and years ago showed that women should not take aspirin for primary prevention of cardiovascular disease, but that it's helpful for primary prevention of strokes. And I see all these women coming into the emergency department already on aspirin. I'm like, why? Have you had a heart attack before? And they're like, no, it said it was good for me, or my doctor told me. And then they come in with GI bleeds. Ibuprofen, less effective in women? I mean, this is where I'm like, how? Tell me more. Like, what do these sex differences mean at the cellular level? And this is my last slide. And it really demonstrates down to the level of plaque buildup, right? So men are most likely to have the top part. So so if you squirt dye and angiogram and you look and you're like, when you think about metabolic syndrome, their fat distribution is very focal, just like it's focal right there. So what's going to happen is, maybe we can just put a stent in there and we just fix the anatomic problem with an anatomic solution. But women distribute plaque and distribute fat much more diffuse. And that's happening at the level of the artery, right? So what happens is that patient that I presented, she's going to, maybe, after she goes to the GI doctor and the rheumatologist and the orthopedic and then the psychiatrist, maybe at some point someone will do a cardiac catheterization, and when they squirt dye, we're not going to see anything but, it's not your heart. It's not your heart, right? When this has real true effects and outcomes. I mean, when she walks up the stairs, it's gonna prevent blood flow. So these are just the things that are shocking to me. And I've been in this field for a long time, and so it's it's just exciting to think about from a research perspective, and then from an outcome perspective from patient care. Yeah.
I just have to go up.
Yeah.
The paper that you were just presenting on, it had said gender differences at first and then sex differences after.
Yeah.
Was there actually any difference in how they determined that? Did they actually do that based on gender?
No,
sex,
that
or
entire
sex?
paper should have been called sex
Sex,
differences.
okay.
Yes, exactly. So that just wasn't picked up.
Until like the third table for some reason?
Yeah, exactly. And so think about that. The editors should have picked that up. Peer reviewers, we all, put all this time. And so, these are things that you have to just be more aware of. And so wherever you have control, if you ask to review a paper and you say, the table one only has the demographics, and you're like, oh, okay, some women were in there. But no, look to see actually what's happening, and they need to be held accountable now for the growing vocabulary, because that's going to change our understanding of what the mechanisms are.
Thank you. Sorry, I have to go.
That's okay. You're fine.
So the next part is on sex and gender differences in obesity and lifestyle intervention for weight loss. Dr. Connie Newman, who's an endocrinologist, was actually supposed to give this talk, but she was not able to. However, she did record her talk, so I'll play it for you.
Hello, I am Dr. Connie Newman. I'm an endocrinologist and board-certified specialist in obesity medicine and an adjunct professor of medicine at New York University Grossman School of Medicine. I would like to thank the AWAEM and the Sex and Gender in Emergency Medicine Interest Group for their invitation to speak at this meeting. We now know that obesity is not a lifestyle choice, but rather a disease characterized by excess body fat and changes in gastrointestinal hormones and satiety and hunger centers in the hypothalamus. Importantly, obesity is associated with multiple comorbidities, including diabetes and cardiovascular disease. I have a special interest in sex and gender-based differences in health and disease and co-edited a 2021 medical textbook on this topic. The title of my presentation today is Sex and Gender Differences in Obesity and Lifestyle Interventions for Weight Loss. I have no disclosures. The first part of my presentation will provide an overview of sex and gender differences in obesity. I will cover the prevalence of obesity, the difference in adipose tissue depots in men and women, the regulation by estrogen of fat metabolism and energy balance, how appetite and cravings differ in men and women, and food cravings during the menstrual cycle. In the second part of my presentation, I will summarize studies of lifestyle interventions to achieve weight loss. This table shows how obesity and overweight are defined by the National Health and Nutrition Examination Survey, known as NHANES, and this was done in 2017 to 2018. Overweight is defined as a BMI between 25 and 29.9, obesity as a BMI of 30 or above, which includes severe obesity, and severe obesity as a BMI of 40 or above. Data from the 2017 to 2018 NHANES survey show that close to 1/3 of adults are overweight, 40% have obesity, and the prevalence of overweight is less in women than men, and also that severe obesity is more prevalent in women compared to men, with 11.5% of women having severe obesity compared to 6.9% of men. This slide shows 2017 to 2018 U.S. data, again from NHANES, on the prevalence of obesity in adults, with the data disaggregated by sex, race, and Hispanic origin. Women are represented by the pale orange color and men by the red color. In this data set, the prevalence appears lower in non-Hispanic white women. What is most striking, however, is the data in Black women. 57% have obesity compared to 41% of Black men. For Asian men and women, the prevalence of obesity does not differ and is lower compared to other races. For Hispanic men and women, the prevalence of obesity is about 45% with no sex difference. I've included this slide to remind us of the basic principle that fat accumulates if energy intake is greater than energy expenditure. Fat cells can hypertrophy or can multiply, and with time, excess energy storage leads to obesity. There is a well-known sex difference in fat distribution. Women accumulate fat in the subcutaneous tissue, particularly in the upper legs, while men accumulate fat in the visceral area, as shown here. Visceral fat is associated with higher risk of cardiovascular disease. As a result of these difference in the fat depots, women have a gynoid shape and men an android shape. Percent body fat is generally higher in women than men. We have learned a lot in the past few years about the characteristics of adipose tissue in persons with obesity. On the left, we see normal fat cells. On the right, we see hypertrophied fat cells in obesity, and these adipocytes secrete pro-inflammatory adipokines that may adversely affect the heart. The sex differences in adipose tissue that I mentioned may be due to genetic, epigenetic, or hormonal factors. Among the hormones that affect fat accumulation and obesity are estrogen, testosterone, and other androgens. Studies of estrogen have shown that estrogen has an important role in energy balance. It acts on pro-opium-melanocortin neurons in the hypothalamus to decrease food intake. Estrogen also acts on neurons in the ventromedial nucleus to stimulate physical activity and energy expenditure. Under normal physiological circumstances, estrogen acts in multiple organs, shown here, to promote energy balance, promote survival of beta cells in the pancreas, and also insulin sensitivity in the liver and in muscle. Estrogen is also important for lipid metabolism in the liver. It is not surprising that estrogen deficiency, such as in the menopause, is associated with obesity, inflammation of the visceral adipose cells, beta cell dysfunction, which can lead to type 2 diabetes, and insulin resistance in both liver and muscle. The response to weight reduction in terms of fat lost and lean body mass lost may differ in men and women. These data are from a study of 1,504 women and 720 men who have pre-diabetes, and the intervention was an 810 kilocalorie daily diet for 8 weeks. The orange bars represent the women, these are the orange bars, and the red bars represent men. There was a mean 2 kilogram difference in weight loss between men and women, with men losing more weight. What is of interest is that loss of fat was significantly greater in men compared to women, and the loss of lean body mass was greater in women. So in this study, men had a more favorable response to the low-calorie diet. Data from the UK Biobank, with over 200,000 people represented in this analysis, show that women eat more sugar, total fat, and saturated fat than men. Another study concluded that cravings differ in women and men. Women crave sweet foods like cake, chocolate, and ice cream. Ice cream is my favorite. And men crave savory foods such as meat, fish, and eggs. Food cravings appear to vary during the menstrual cycle. Cravings are shown here in the dotted line, and you can see that in the luteal phase of the menstrual cycle, when progesterone rises and estrogen and progesterone fall, cravings increase. So you see this here. In summary, sex and gender differences occur in adipose tissue distribution and response to weight loss, also in macronutrient intake, food cravings, and comorbidities associated with obesity. Estrogen has an important role in energy balance, and estrogen loss with menopause is associated with insulin resistance, diabetes, and cardiovascular disease. A greater understanding of sex and gender differences in adipose tissue and obesity could lead to novel approaches to weight reduction and weight management. In the second part of my talk, I will cover sex and gender differences and effects of lifestyle interventions on body weight. We have yet many unanswered questions about effects of lifestyle interventions on weight loss in men compared to women. First of all, is there a sex difference in weight loss? Do men and women have specific preferences for types of lifestyle interventions? And does sex and gender have a role in adherence to lifestyle interventions? Clinical trials comparing effects of lifestyle interventions in men and women have inconsistent findings. In trials with fewer than 1,000 patients, there was an imbalance in men and women, and only 5 of 21 trials evaluated percent weight loss, and most of these trials looked at absolute weight loss, which is really not the relevant endpoint. In these trials, any effects on body weight were small, and most trials did not pre-specify comparison of sex and gender differences and were not powered to study such differences. This chart summarizes sex differences in weight loss from clinical trials, 1 meta-analysis, and 2 trials evaluating maintenance of lost weight. In 3 trials of diet and exercise, shown here, weight loss was significantly greater in men by 1.6%. In a meta-analysis of 13 trials evaluating weight loss, the difference in percent weight loss did not differ in women compared to men. However, this data had limitations. There were a small number of subjects. The trials didn't assess adherence or whether management in men and women was comparable. In maintenance trials evaluating whether lost weight could be kept off, no sex differences were found. And these trials were the Keep It Off trial and the weight loss maintenance study. In 2 large trials with about 5,000 participants, the Diabetes Prevention Program, where the primary endpoint was diabetes, and the Look Ahead trial in patients with diabetes, where the primary endpoint was cardiovascular disease events, there were no difference between men and women or percent weight body loss, or a very small difference. Again, there are caveats about these trials. There was an imbalance in the numbers of men and women enrolled. Weight loss was not a primary outcome, and these trials were not powered to detect sex and gender differences. Although the data are certainly not definitive, some trials suggest differences in preference for lifestyle intervention. In Keep It Off, women were more likely to choose commercial weight loss programs. In the Lighten It Up trial, there was a choice of 8 weight loss programs, and fewer men chose commercial programs. Some investigators hypothesized that men prefer simple, fact-based language with individual feedback. It would be worthwhile to know whether weight loss would improve with sex and gender-tailored interventions. However, much more research is needed. In conclusion, more randomized controlled clinical trials are needed to determine whether sex differences exist in weight loss due to lifestyle interventions. Percent weight loss in men and women should be the primary endpoint in these trials, and sex differences should be pre-specified. The hypothesis that lifestyle interventions will be more effective if tailored to men and to women should be studied. Thank you for your attention. Should you have any questions after this meeting, please feel free to contact me by email at connie.newman@nyulangone.org.
All right, so that was a good overview of the sex and gene level of how things work. So I'll just briefly go over the cultural and social differences of obesity. So there's this idea out there that obesity is a social contagion, and contagion in the sense that it can spread just like any infectious disease. And the basis for that was based on studies that found a tendency for obesity to spread among peer clusters. So there were a lot of studies on adolescents that showed that an adolescent's weight correlated with his or her peers, and obese friends led to you being more likely to be obese yourself. And this persisted into adulthood. And similarly, like studies that looked at physical activity levels in adolescents and eating habits also found similar effects, like you kind of do what your friends or peers do. So then from that, the biggest study on this idea of obesity being a contagion was by Christakis and Fowler, and that was a 2007 study. So they used data from the Framingham Heart Study, which looked at participants over 32 years. In their study, they call the main subjects as ego, and anyone that's in their network are called alters. And so together they made up this social network. And they found some interesting things. Between friends, the risk of obesity increased by 57% if their alters or network, people in their network were also obese. And in same-sex friends, they found that a man had 100% of being obese if his friend was also obese. And in women, like female-to-female friendships, that really wasn't significant. And they also didn't find any significance in opposite-sex friends as well. And then among siblings, they found that 40% overall were likely to be obese if you had some other sibling that was obese. Among sister, it was 67%, and then brothers, 44%. And they also noted that geographic differences or distance didn't really change that effect among siblings and brothers. And then they also looked at married couples, and they found that husbands of wives who are obese were 44% more likely to be obese themselves, and then for wives of husband, 37%. So they thought like maybe this is because people are more likely to pursue like a group norm and ideals to fit in, and that's why people were more susceptible to obesity if their network were as well. So this shows that, obesity is socially contagious, but like the notion if it's gender or not, is really unknown. And I think like based on like the data and the differences in lifestyle intervention that Dr. Newman mentioned, suggests that, it really isn't socially contagious by gender, but overall the concept may hold. And, there's a lot of limitations with like the studies on these sex and gender differences in obesity. As Dr. Newman mentioned, there's unequal numbers of men and women. There's limited data on the percent change in body weight. There's lack of studies that define how sex differences in weight loss as a primary endpoint. They didn't really look at that. And then there's also like problems with their methodology. A lot of the studies were only looked at for a 6 months period, and they didn't go beyond that. And I think it's important to look at the long-term effects. So just some future studies and consideration. We really need to think about more randomized control studies that look at the primary endpoint of these differences in men and women in weight loss. And we need to look at different interventions and how that compare and extend the study to longer than 6 months. Overall, I think the idea that obesity is a gender contagion is not supported by current research, and we need to do more to understand it. So that's it. That's all we have.